turbo engine running.
Absolute genius.
Get this.
Welcome.
This is the show where we bring you
Science.
What that essentially means is
discoveries,
Advances.
questions,
Research.
technology.
Unbelievable.
Without further ado,
This is The Naked Scientists.
Hello and welcome to The Naked Scientists, the show where we bring you the latest breakthroughs and talk to the major movers and shakers in the worlds of science, technology and medicine with me, James Titko. This week, the growing crisis in the mental health of younger people.
I remember the first time I went outside of the hospital and I went out for dinner with my mum and I looked in the bathroom mirror in the restaurant and I looked at myself and I just wanted to disappear.
Why are so many young people afflicted by a decline in their mental health and well-being, and what are the solutions?
From Cambridge University's Institute of Continuing Education, this is The Naked Scientists.
The mental health of the young is reaching breaking point globally. A recent analysis by a panel of leading researchers, young people and policy experts has warned that without targeted action, by 2030, 42 million years of healthy life could be lost to mental illness or suicide. That's 2 million more than 10 years ago. The latest Lancet Commission on Adolescent Health and Wellbeing found that rates of anxiety, depression and other mental disorders are rising across every region in the world. The key aggravating factors appear to include digital exposure, climate anxiety and social instability, which are not only reshaping the world we live in, but the landscape of youth mental health. Sarah Baird at George Washington University is the Commission's co-chair.
Mental disorders and expressions of distress, things like self-harm, are the largest cause of disease burden among adolescents across all countries. And we use this term called disability-adjusted life years, and they're associated with 42 million disability-adjusted life years as of 2022, which is close to a fifth of the total disease burden among adolescents. So really driving their well-being today.
Those are big numbers. Is this a problem that's getting worse?
Yeah, 100%. There are still challenges with data collection, particularly in low and middle income countries, but without a doubt, across the board, we're seeing increases, whether it's looking at anxiety or whether it's looking at suicide. We also see that it manifests differently between boys and girls, with increases among girls, particularly around depression and what are called more internalizing behaviors. While for boys, it tends to show itself more in conduct disorder and misbehaving. So these more sort of external expressions.
That's interesting. If you were to listen to the public conversation around this, you get the impression that the digital environment is potentially a big factor in all this, the one that our children are growing up in now. Is that something the Commission looked into?
Yes, we spend quite a bit of time talking about the role of the digital transition and its connection to the increases in mental health. It's a very complicated space with many people on both sides of the debate. My sense is there are components of the digital space that are likely harmful for young people, whether that's misinformation or harmful content, or it's linked to physical activity. So in terms of screen time substituting for being outside, but we also see a lot of good coming from access to digital technology. And the increasing trend started well before this massive increase in digital. So I think there are some important linkages, but I think it would be incorrect to say that the digital transition is what has caused this increase in mental health.
So it's not all social media. What other factors have you identified as responsible for the growing disease burden of mental health in adolescents?
Climate change, conflict, and the COVID-19 pandemic and the roles that they're playing in adolescent mental health. Decreases in biodiversity and declining green space has adverse impacts on mental health. The impacts of the COVID-19 pandemic are still strong today. Social isolation, the lack of access to schools, and then what seems like a daily increase in conflict globally is directly linked to mental health as well. And so I think the power of these mega trends are really playing also a strong role in influencing adolescent mental health.
Aside from being the source of a lot of suffering for youngsters, what's the effect of poor mental health in youth for someone's prospects across their life?
We found really strong associations between mental ill health in adolescence and a wide range of outcomes in adulthood. So both mental ill health in adulthood, but then a wide set of physical outcomes as well. Let's say sleep or obesity or blood pressure or migraines.
Purely from an economic standpoint, then, it's going to make sense to invest in young people's mental health. Is that reflected in the provision of services?
No, for those of us in the adolescent space, that's the case that we've been just trying to make, is that this is a win-win, right? You're improving their mental health today, but then that has long-lasting effects on their life as adults, including their life as productive members of society, which then translates into the next generation. But the investments in adolescent health and well-being overall are dire. But then when you look at mental health specifically, the amount of funding going to mental health among adolescents globally is tiny. For example, we look at a database development assistance, so investments by high-income governments or multilaterals into mental health in low and middle income countries, and we find that on average, investments sit at about 7 cents per adolescent.
We're exploring the idea that disentangling physical and mental ill health is less clear-cut than previously thought. And I know your commission focuses on well-being overall as well.
Yeah, I think as you think about it more just from how all of our day-to-day lives go, these things are intricately linked. Another trend that we note in the commission is extremely high rates of overweight and obesity and how that's projected to increase into the future. And then there's strong links between obesity and adverse mental health. So I think ultimately investing in mental health is good for physical health and vice versa. And I think the more we consider these linkages, the more progress we'll be able to make, particularly in preventative measures that impact both mental and physical health.
It's worrying, isn't it? That was Sarah Baird at George Washington University. So now we know the scale and some of the causes and outcomes linked to the problem. How should we go about fixing it? Tamsin Ford is a professor of child and adolescent psychiatry at the University of Cambridge. She argues that we need to become much better at spotting the problem in the first place, perhaps before it becomes severe and harder to manage. But we seem to have a problem doing that. Why? And on the flip side, are we overdiagnosing variants of normal?
I think they're harder to spot because we don't train people and encourage people to look for them. You can't go anywhere near a hospital or a clinic or a GP surgery without someone taking your blood pressure. And that is because we know strokes and heart attacks are so devastating. There are simple questions you can ask and simple assessments that can be done that would quickly and efficiently and effectively identify the children who are struggling. It's just that we need to make it part of the care that we offer everybody.
We're talking about interventions with limited resources, the interplay we're keen to stress on physical and mental health. Perhaps those who we've identified who have physical health conditions might be appropriate to target.
Yes, it depends a little bit what condition you have. If you have a condition that involves your brain or spinal cord, the likelihood of having a mental health condition is huge. It's approaching half of those affected in childhood and adolescence. For pretty much every medical condition, it's 2 or 3 times more common.
Given all that, where is the best place that we can direct our resources to be able to make the crucial differences?
I think we need to go to where children and young people are. Every contact between a child and their family and a practitioner is an opportunity to detect a child who's struggling and to intervene to alter their developmental trajectory for the better. We are really lucky in the mental health field in that we have a lot of evidence-based interventions that are highly effective. I think where we lack sometimes is the workforce, and we need to get smart. So Cambridge was involved as a site in a study where we trained epilepsy nurses to deliver from manual of evidence-based treatments for anxiety, for depression, for behaviour problems. Any child with epilepsy who had a mental health condition on a standardised assessment got access to the intervention, and it was effective and cost-effective a year or 2 later.
There are some voices who would argue that we're starting to pathologise what are natural differences in young people especially. So keen to get your views on that.
It is a really hot topic. It is one that deeply worries me. There is no doubt we've had a massive increase in diagnoses of both autism and ADHD. We've also had a massive increase in prescriptions of ADHD medication. In fact, our own government-supported official statistics on the number of children with mental health conditions demonstrates that there hasn't been an increase in the number of children in the population who have ADHD or autism. But those who are getting medication for ADHD have gone from 30% to 60%. There was no evidence of overprescription. So there wasn't a single child in this national survey of more than 9,000 children. There was no evidence of children who didn't have ADHD being prescribed ADHD medication. So yes, our prescriptions have gone up and the demands for diagnosis have gone up, but we are not seeing evidence that we are pathologising people who do not have problems. We have more people coming forward because I think people are more aware, and that is a good thing, but we do need to try and sort the problem out with assessment taking years, because whilst people are waiting for that diagnosis, they're often not getting the support they need. And that's another thing we can correct, helping empower schools and other places to put in support for people before they get the diagnosis. Why wait, particularly if it's going to take years? If you think there is a problem for a child with their attention, there's lots of stuff you can do.
Tamsin Ford, Professor of Child and Adolescent Psychiatry at the University of Cambridge. Tamsin is also involved in the creation of the new Cambridge Children's Hospital, which we'll hear about a bit later on, the role it's going to play in tackling the crisis in adolescent mental health, we hope. You're listening to the Naked Scientist podcast with me, James Titko, and this time we're exploring the emerging crisis in young people's mental health worldwide. As a rule, the best outcomes for any medical issue are usually achieved when problems are picked up early. Anna Moore-Winter at the University of Cambridge's Department of Psychiatry is aiming to do this for mental illness by harnessing the latest technology in the form of a digital tool she's developing called Cadra. It uses health information routinely collected at places like GP practices and schools to look for red flags that can highlight vulnerable individuals and earmark them for extra help next time they're in contact with medical services.
All the information about us when we are interacting with health systems is often recorded, but we've all got lots of stories we can tell about how we've gone to see one doctor and then another doctor, and no one knows the whole story, and we have to repeat our story over and over again. And exactly the same happens with data, the information about us. So one of the things we're doing is to try and think about, is there a way that we can bring all of that data together so that we can, first of all, understand how the systems work and the health system that we're designing, whether it works well together, but also if we can use that data to try and spot patterns really early, which might indicate a mental health problem or some problem with well-being, so that we can really think, is there a way that we can use these digital tools that are being developed to help people know, is there a problem, and then figure out what to do about it.
Could this be, if we take maybe the epilepsy example from earlier, the idea that we hear how the treatment's gone in the hospital, or we look at school data from how many days they've missed, and combining that we can build a picture and potentially stage an intervention?
That's exactly right. So people they're born with a genetic predisposition to different disorders, but then stuff happens in life, like from really early. But that information is often in your GP record, or it might be your school record. We know that when young people are struggling or difficult things happen in life, like maybe they don't go to school as much, they might have more time off. So there's all these different bits of information about us in the system. And if we can piece that all together, and we can figure out, are there patterns that indicate that someone might be having a problem, then actually that means that we might be able to flag that really early. So the first time you go to see like the GP and you're referred into the Children's Hospital maybe for your first seizure, actually it might be that we've got a bit of a sense of other things that are going wrong, and it can flag up and say actually there is potentially a well-being or a mental health issue here that we really do need to talk to that young person, the family about. So we're hoping it just might kind of systematise the way that we approach that.
I mean, it sounds awfully ambitious, from genetic predispositions all the way through to missed days from school. Quite an undertaking. And this is all not to mention so far working with vulnerable young people, collecting all that data and making sure it's done in a safe way.
Absolutely, and that's been fundamental, probably one of the most important parts of the programme. So we've worked with around 200 young people and parents and guardians from across the region to really help them to understand the approach and how we're doing it, and to make sure that it's something that seems acceptable and it's something that they wanted. And interestingly, one of the things that really came through in the consultation work we're doing is that people are saying, actually, this is already happening in cancer and it's happening in eye health, so why aren't we doing it in mental health? And it's really important that we have the same opportunities to access these tools that people who have got just physical health problems, although as we all know, no one has just a physical health problem, but people who are there primarily for that. But I would say that when we were doing that consultation, one of the things that came through was how it was really critically important that we thought about people from different backgrounds.
This is what people always say about big data and finding patterns in these data sets, is that you run the risk of accentuating imbalances or the biases that are kind of baked in.
Absolutely. So we spent a lot of time really understanding what the data meant with people from different backgrounds. And one of the things that really came out is that depending on what your personal experience is or your cultural background might be, actually a data point for one person might mean a completely different thing for another person. And so if we look at the assessment of the evaluation of the effectiveness of digital tools, it's really common that they're really effective for basically posh white people. And that's kind of not okay. So if we're building these tools and we're building for our system, they need to be helpful for everybody. And so it's critically important that we have particular programs and streams of work that help us really understand how we can build tools that are equitable for all. It's really important that the data sets we use represent everybody in them.
Anna Moore-Winter on how big data can be a powerful tool for improving early pickup of evolving mental health problems. Another cause of childhood mental ill health is the trauma of physically being in hospital. As we've heard already in the programme, being diagnosed with a physical illness places a young person at significantly higher risk for developing a mental health problem later in life. Charlotte Rye is someone this happened to. She told me how surgery for a spinal injury led to her developing body image issues and an eating disorder.
It really all started when I was 13. I ended up breaking my spine in 2 places, and that meant that I had to have surgery. And I was really lucky. I was able to have this surgery in a specialist children's hospital. But of course, it was hours from home. My friends and family couldn't visit very easily. I wasn't actually in hospital for too long, a couple of weeks at most, but the issue was the first surgery failed, so then I had to stay in a lot longer than I was planning to wait for a second surgery. And during that time, essentially, I was left to recover from quite severe surgery, largely alone.
So the offer from staff was not right to meet your needs from the mental health perspective. Naturally, I suppose, they were concentrating on getting you fit and firing after your spinal injury.
Exactly, it's exactly that. The staff were absolutely incredible, and I was up and walking within 24 hours of my surgery. But to them at the time, that was the important thing. And I do look back and wonder, had I received some support perhaps earlier on, whether actually the outcomes for me would have been very, very different.
It must be difficult to talk about, but can we talk about how it kind of progressed then after that and how your mental health deteriorated?
So I think the big thing for me was after I came out of surgery, I had to wear a back brace for over a year. I wasn't able to do the things I love, like dance, and it almost felt as if people were looking at me differently and treating me as very differently to them. And I think that was just led to such a decline in my mental health. I remember the first time I went outside of the hospital and I went out for dinner with my mum, and I looked in the bathroom mirror in the restaurant and I looked at myself and I just wanted to disappear. Right. And that was the start for me. I just wanted to disappear. I didn't want anyone to see me. And I think that was the start of the restrictive cycle. And from then it was 4 years. I was then an inpatient in a psychiatric hospital. I was in a general psychiatric unit. They didn't have expertise in looking after young people with eating disorders. And obviously, being in hospital itself is a very traumatic experience. We know that 1 in 3 children, it's 1 in 5 adults who have a prolonged stay in hospital will develop post-traumatic stress disorder. And obviously, those statistics are alarming. And unfortunately, I was that 1 in 3. And I think it largely stems from the lack of autonomy, the lack of control you have at this critical time point, really, is the crux of it.
Charlotte Rye. With the risk of this sort of outcome in mind, an innovative new hospital just off the drawing board here in Cambridge and due to open its doors in 2028 is pioneering a much more holistic approach by treating mental and physical health together. It's hoped giving mental health more prominence and consideration will reduce the risk of legacy psychological problems. Isabel Heyman, consultant child and adolescent psychiatrist and an honorary professor at the Great Ormond Street Institute of Child Health, is one of the leaders behind the new project. I met Isabel at Addenbrooke's Hospital, a stone's throw from where the new site is currently under construction.
Traditionally, mental health has always been the poor relation of physical health. So I think one of the things we're really trying to do is make sure that mental health care is as good and as timely, as accessible, as effective as physical health care. I think what's particularly wrong in mental health is that it's a bit variable across the country. We have some fantastic treatments in child mental health. For example, treatments for anxiety have an 80% chance of getting children better, but it's a bit of a lottery as to what you get.
As much progress has been made, it feels like, with people like us having conversations like this, trying to put mental and physical health on an equal footing, probably be fair to say it's still not reflected in the reality, and there's still a stigma attached to mental ill health.
Yes, I think that without a doubt there is still misunderstanding and stigma with mental ill health. And we really hope that at Cambridge Children's, by bringing physical and mental health together, we're going to tackle that head on. We've decided for Cambridge Children's to really bring them together, mind and body, to fully integrate them, which means we're going to have the wards for children with mental ill health alongside the physical health wards, intensive care units, those sorts of things, when we're also going to have beds where somebody could be admitted with either a physical or a mental health problem. All the rooms are going to be individual, and we're calling these the universal beds. And also the third arm is bringing cutting-edge research into the hospital. So we're going to have the whole of the ground floor is a research institute, and the focus is really going to be on early detection of illness, both physical and mental, and early intervention. So really thinking about prevention.
One of the things that's come across is the trauma of coming into hospital and getting treatment for your physical health conditions, and how perhaps that's being underappreciated.
Yes, and thinking about trauma is something that's really central to the Cambridge Children's model. So we're not going to imagine that everybody's going to be traumatised, but we are very aware of that statistic, that 1 in 3 children will be traumatised significantly. And there are ways of mitigating that. And some of the things that both of your interviewees spoke about was things like communication, autonomy, making people feel that they have some control over what's happening to them, including their network, their family, their siblings, putting the young person and their voice at the centre of care. All of those things are really important to the model we're going to be working with at Cambridge Children's.
When you were applying for the grants and getting the project off the ground, did you have any kind of flagship research or evidence that you were using to demonstrate what this integrated approach might be?
We do see ourselves as breaking new ground, and we hope to have a model that others will want to copy. There was a lot of evidence from the States showing that if children were admitted with a physical illness, a paediatric illness to hospital, and they also had mental ill health. They stayed in hospital for longer, they cost more, and they were readmitted more often. So there was already evidence around the world that detecting and treating mental ill health alongside physical ill health was beneficial. And then with colleagues, we did look at some specific groups of children. So, for example, children with epilepsy have particularly high rates of mental health need, emotional and behavioural problems, so common things like anxiety, depression, challenging behaviour. And what we showed was that we could easily detect these problems in children. They often weren't spotted or screened for, or people had put down the fact that, for example, they were refusing to go to school or play with their friends. They'd attributed it to the epilepsy, whereas actually that child, for example, had become very socially anxious, which is a very treatable problem in its own right. So what we showed was that we could train nurses and other staff within epilepsy clinics to deliver brief evidence-based mental health interventions, and that the children in the trial who got that intervention did significantly better than children who didn't in terms of their quality of life and their emotional and behavioural symptoms.
Isabel Heyman, psychiatrist and fellow of Murray Edwards College, Cambridge, and clinical co-lead for the Cambridge Children's Hospital, which is due to open in 2028. I'd heard it said before that mental and physical ill health are really one and the same, but I'm not sure I fully appreciated what that meant until now. While certain conditions may present primarily as either physical or mental, it's increasingly clear that they send ripples across all aspects of our well-being. And when we look at it this way, it's obvious that we'll serve everyone, especially young people, much better if we truly integrate our understanding of health as a whole. Tackling the adolescent mental health crisis isn't just about grand plans, but about getting the basics right. We need better data to understand what young people actually need, proper funding for health systems, and smarter ways to spot problems. Crucially, we also need to support younger people in a way that makes sense to them. When we do that, we're not just fixing problems, we're giving them the best shot at a better future. Next time, Titans of Science returns for the final instalment of the season. Cambridge microbiologist Sharon Peacock will be talking to Chris Smith about her work sequencing the COVID-19 virus during the pandemic. The Naked Scientists comes to you from the University of Cambridge's Institute of Continuing Education. It's supported by Rolls-Royce. I'm James Titko, and from everyone here at The Naked Scientists, thanks for listening, and until next time, goodbye.